This conference will now be recorded.
Anemia in pregnancy. So anemia means that there is less hemoglobin in the body, and in pregnancy it can be physiological or it can be pathological. If we follow the definitions, then at the time of booking, when you are booking the patient, that is usually at 10 to 12 weeks, the hemoglobin level should be 10.5 grams per deciliter. At 28 weeks of pregnancy, the hemoglobin level should be 10 grams per deciliter or more, should not be less than this one. And in the post-op period, it should be 10.5 grams per deciliter. The point is that if it is 11 at the start of pregnancy, that is even better. So we can say that WHO definition is that at the start of pregnancy, hemoglobin level should be 11 grams. At 20 weeks, it should be 10.5, and in the postpartum period, it should be 10 grams per deciliter. So if it is less than 10 grams, then we will say that patient has anemia. The problem here is that many signs and symptoms of anemia, they seem normal during pregnancy, like fatigue, feeling tired all the time, and loss of mental, this attention and concentration, and feeling sleepy all the time, feeling cold. All of these are considered normal. So that's why, it is masked. Then second point is that women who are becoming pregnant, they are usually younger people, younger women. So what happens that they will not show any signs and symptoms, while at the same hemoglobin level in the older age group, you will see that they will become symptomatic early and they will take the treatment. If we divide anemia, we can do this division on the basis of many factors. But the easiest one is if you will divide anemia on the basis of their size. Yesterday we read about the mean corpuscular volume, that how much is the surface of the RBCs, and we read that the normal is between 79 or between 76 to 96. That is the mean corpuscular volume. Now, in cases of anemia, what happens that this volume has changed. It may increase, it may decrease, or it may remain the same. So that is also a possibility. So that's why when you are talking about anemia, you are not relying on just one factor. Depending upon the size, anemia can be microcytic, normocytic, or macrocytic. Microcytic anemia means that the mean corpuscular volume is less than 80 fluid ounces. So then in the normocytic, the mean corpuscular volume is between 80 to 100. And if it is more, MCV is more than 100, then we will say that this is macrocytic anemia. Regarding microcytic anemia, it can be due to many factors, like maybe the hemoglobin will be affected. It can be due to defective globin chains, which can occur in cases of thalassemia, both thalassemia A and thalassemia B. Then there can be defective synthesis of heme. It can occur in anemia of chronic disease. Then it can be iron deficiency anemia, but initially the patient will not present with anything, but it can occur in the later stages of pregnancy. Then, in cases of lead poisoning, especially in the children, okay? But the women, they can also be affected. Regarding the normocytic, when the mean corpuscular volume is between 80 to 100, it can be non-hemolytic or hemolytic. Non-hemolytic means here the patient will have low reticulocyte index. I will tell you in a while what is reticulocyte index. And normocytic and non-hemolytic anemia, it is seen iron deficiency anemia, and it becomes symptomatic early. Then anemia of chronic disease, aplastic anemia, and the chronic kidney disease. So remember, patient will be anemic, but the size can be normal. Then it can be hemolytic. Whenever there is intravascular hemolysis, the reticulocyte count is going to increase and the LDH level will also be high. So this hemolysis, it can be due to some intrinsic problem or due to some extrinsic event. Intrinsic events, like there were membrane defects, like there was hereditary spherocytosis, like they were too much spherical, these RBCs. So they were fragile and they are breaking down. Then paroxysmal nocturnal hemoglobinuria. This is also an abnormality where the patient is going to present with, when they will get up in the morning, they will pass brown urine. We'll talk about it also. It can be due to enzyme defect, like the most common one is glucose 6 pyruvate dehydrogenase deficiency, or we can say pyruvate kinase deficiency. Then there can be hemoglobinopathies like sickle cell anemia and then the hemoglobin C disease. It can be extrinsic, like it can be secondary to autoimmune phenomenon. It can be due to microangiopathic. It can be due to macroangiopathic, like there are problems in the blood vessels, or it can be due to infections, like in cases of aplastic anemia, where whole of this bone marrow, it has been rendered functionless, like in cases of parvovirus infection and some other infections. If mean corpuscular volume is more than 100, then you will say that this is macrocytic anemia. Macro as you know means that the size is large. So it can be megaloblastic, like it is associated with increase in the size of the cells, or it can be non-megaloblastic, like the cells, their size is not increased. In megaloblastic anemia, mostly what happens that bone marrow, it will have erythroblasts, and these erythroblasts, their DNA is defective, so they will take a longer time to mature because of the defective DNA synthesis. So it can be due to secondary to deficiency of folate, or due to deficiency of vitamin B12, or due to deficiency of, or due to a condition which is called orotic aciduria. This is also a defective synthesis. Then defective DNA repair, like in cases of Fanconi anemia. Then it can be non-megaloblastic, like the size of the cell has not increased. So it can be seen in many conditions, like in diamond blackman anemia, that is also inherited syndrome, then in liver disease, then in alcoholism, and even in pregnancy you are going to see macrocytic macrocytic anemia, but that will be without megaloblast, like in pregnancy. So size of the cells will be fine, but we can have it. In pregnancy, you will see macrocytosis without megaloblastosis. It is also seen in the neonates, then in the aplastic anemia, and then if the patient is taking some therapy like azathioprine, so they can have this non-megaloblastic anemia, and also in cases of reticulocytosis, which can be due to any cause. Okay? So what is reticulocyte index? This is also called corrected reticulocyte count. It is used to correct falsely elevated reticulocyte count in anemia. Measures appropriate our bone marrow responses. It is the reticulocyte index. It is going to measure appropriate bone marrow response to anemic conditions, like the erythropoiesis is effective or this is defective. High reticulocyte count index, it indicates that compensatory RBC's production has taken place. Like high count tells you that there was anemia, but now the bone marrow is working well. And so there is enough number of these reticulocytes because the bone marrow is functioning. If reticulocyte index is low, it will tell that bone marrow is not responding well to this anemia, and the response of bone marrow to anemia is inadequate. How do we calculate it? In your exam, they don't ask you, but in case, if they ask you, then you should remember that reticulocyte index is equal to percentage of the reticulocyte multiplied by actual hematocrit, and then what should be the normal hematocrit. Like you are calculating for the woman, it is going to be 45. For the men, it is going to be 50. So it is just going to tell you what is the status of the bone marrow. So the most common type of anemia worldwide, this is iron deficiency anemia, the most common one. Okay. So what happened here? This is caused by blood loss. When do we lose blood? In cases of menorrhagia, PPH, or maybe the patient has some ulcer in the gastrointestinal tract which is bleeding, or then it can be due to increased demand. Two types. Increased demand, like when the person is growing up, so due to growth spurt, and then secondly in the pregnancy because there is the mother is providing for another individual. There can be two causes. Either the person is not eating well, or she's not taking the diets rich in iron, or the second thing is that she is taking diet but it is not absorbed through the GLT, like in cases of celiac. So your patient is going to have poor absorption. And the commonest cause of iron deficiency and deficiency anemia in the whole world is hookworm infestation. So here the mean corpuscular volume will be less than 80, and the mean corpuscular hemoglobin, it will be less than 27 picograms. So if you will look at the shape of the this RBCs, you can see the variation. Then you can see the variation in the size of the cells also, and then you can see the target cells also. What are target cells? These are broken RBCs. That is the point. Okay? So in iron deficiency anemia, the serum iron, it will fall, and when the serum iron will fall, then there will be a rise in the iron binding capacity of the, I can show you here. That's what will happen in cases of anemia, like if in iron deficiency, serum iron will drop. Transferrin, which is the carrier protein, or the total iodine binding capacity of the body, it will increase. Ferritin, which is the stored form of hemoglobin, it will also decrease. And transferrin saturation, it will also decrease tremendously. So these are the features of iron deficiency anemia. So the differential diagnosis, it can be like anemia of chronic disease, thalassemia. Okay. So how do we treat the iron deficiency anemia? So we will treat the underlying cause, identify the cause and correct it. And if we are giving the iron replacement, then it is going to increase by 1 gram per week. And ferrous sulfate is best absorbed when the patient is fasting. Then yesterday we read that if there is vitamin C in the system, it is also associated with improved absorption of ferrous. If we will give the ferric form, then ferric cannot be absorbed. It will become into something like organic particle, which will not be absorbed from the body. That's all you need to remember about iron deficiency anemia. Now, the macrocytic anemia, where the size of the blood cells is larger. So, megaloblastic and non-megaloblastic, it can be depending upon the findings in the bone marrow. What happens in the megaloblastic? That the bone marrow, it will contain erythroblasts, but they will have delayed nuclear maturation because the DNA synthesis is defective. So it is caused by vitamin B12 deficiency or deficiency of cyanocobalamin, and basically it can be due to failure of absorption, like in cases of pernicious anemia, where we know that there are intrinsic antibodies against the intrinsic factor. So they will intrinsic factor is required for absorption of folic acid, and what will happen? The person will not absorb any iron from the GIT. Secondly, vitamin B12 deficiency can be there because there is malabsorption, and like in celiac flu, celiac disease. Then there can be a person who is vegan. Vegan means that they are totally taking the vegetable diet. They are not even taking the milk or anything. Then it can be due to folate deficiency also. So the mean corpuscular volume is going to be more than 96. Then we will see hypersegmented polymass in the peripheral blood, which can have like 6 or more lobes, or 6 or more nucleus. So in some cases, when it is severe, then your patient can have leukopenia also. There will be like leukopenia and there can be thrombocytopenia also. So pernicious anemia, it is associated with autoimmune disorders. And among these autoimmune disorders, we can include thyroid disorders, Addison's disease, and also in cases of vitiligo, where is depigmentation of the skin. And if a person has pernicious anemia, it is associated with an increased risk of having cancer in the stomach. So in non-megaloblastic anemia, you're not going to see any changes in the bone marrow. And this type of anemia you are going to see in pregnancy, in the neonates, alcohol abuse, liver disease, reticulocytosis, aplastic anemia, and if a patient is taking drugs like azathioprine. Next variety of anemia, hemolytic anemia. Hemolytic anemia, it can be due to different causes. Like, it means that the cell breakdown has increased and the rate of production of the cells is less and the rate of breakdown of the cells is very high. So it is seen, the hemolysis you can see in cases of, it will be associated with hyperbilirubinemia because too much breakdown of the cells, too much bilirubin is coming into the system and it cannot be cleared from the system. So there will be rise in the urobilinogen, there can be hemoglobin urea, and there can be reduced plasma haptoglobin. If haptoglobin level is low, it means that your patient is having hemolytic anemia. Serum LDH will increase, and in response to anemia, the bone marrow is going to produce many cells. So there will be reticulocytosis, and there will be erythroid hyperplasia of the bone marrow because now the bone marrow is trying to produce more and more RBCs. If we talk about the causes of hemolytic anemia, these can be inherited or acquired. Inherited causes, like the person has hereditary spherocytosis, there was sickle cell disease, thalassemia, glucose 6-phosphate dehydrogenase deficiency, and pyruvate kinase deficiency. Acquired causes, they can be due to autoimmune hemolytic anemia, or they can be due to alloimmune, in which the person has formed antibodies against because she received blood transfusion before and now she has developed antibodies. Acquired hemolysis, it can also be due to transfusion reaction, and then it can be because of certain drugs. And it can be due to, like if the patient has infections like malaria and mycoplasma, then they can also cause the same problem. Then hemolytic anemias, they can also be due to thalassemia. Thalassemia, again, it can be of two types, alpha thalassemia and the beta thalassemia. So in alpha thalassemia, what happens that in alpha globin chains, they are deleted on chromosome number 16. So it will result in reduced synthesis of alpha globin chains. And then there will be deletion of some gene here. And then this type of disorder is more common in the Asians. And it can be of like many different variants. So if one chain is defective, then patient will have alpha thalassemia minor, and it will be a silent carrier, and you will recognize it only if you are investigating the patient for some other cause. If two alpha chains are abnormal, then it is called alpha thalassemia minor, and patient can have mild hypochromic microcytic anemia, but as such, it will have no problem, but it may worsen the outcome for the babies of such mothers. If three alpha chains are abnormal, then we will call it hemoglobin H disease. So it means that excess beta globin is forming, and there will be beta 4. So the patient is going to have, because the chains are defective, alpha chains are defective, so we have beta chains here. So the patient will have moderate to severe microcytic hypochromic anemia. And if all four alpha chains are abnormal, then this condition is not, not compatible with life. So what will happen? This sort of hemoglobin is called Bart's hemoglobin. So it means virtually no alpha globin chains and excess gamma globin chains. They will form gamma hemoglobin. So they will be hydroxypetalous and it is incompatible with life. So that's why we don't see it like that. So again, defective synthesis of globin chain in the adult hemoglobin, and it will cause precipitation of the globin chains in the red cells, and there will be ineffective erythropoiesis. That is the problem. Then the second type of this defect is beta thalassemia. The whole guideline, it was summarized and it is available, and the video is also available in your notes. That is the one on beta thalassemia. Okay, you can go and read it from there also, but here I will revise briefly for you. For the exam, remember that alpha chain is present on hemoglobin on chromosome 16, and the beta chain it is present on the chromosome 11. Don't confuse them. Okay. So in beta thalassemia, there is point mutation in the splice site and the promoter sequence on the chromosome 11. Just remember that defective or decreased beta globin chain synthesis due to changes in the on chromosome 11. It is more common in the people of the Mediterranean origin, like those who are living in Greece, in Turkey, Cyprus, in those areas. Okay. So that's why we ask family origin questionnaire, and if they belong to this area, then we need to do the screening for them. If you know that the mother is thalassemic and you don't know about the father, then we have to do the family origin questionnaire, and if they are found to belong to the high risk group, then we will have to give them further this further assessment to see that they are the carriers or not. Again, this beta thalassemia can be beta thalassemia minor or it can be beta thalassemia major. Beta thalassemia minor is also called heterozygous. Here the beta gene is underproduced. Usually patient will be asymptomatic, and how it is diagnosed, there will be elevated level of hemoglobin A2, like it will be more than 3.5% on electrophoresis. If you remember yesterday's lecture, I said that it is in a normal adult, you can find hemoglobin A2 and the level will be between 1.5 to 3% on electrophoresis. But in this case, if the patient has beta thalassemia minor, the level of hemoglobin A2, it will be more than 3.5%. Beta thalassemia major, this is also homozygous. And what will happen, beta chain is absent. In the minor, the chain is underproduced. But in the major, the chain is totally absent. So patient will have severe microcytic hypochromic anemia. They can have target cells, which are the broken down cells, and they can have increased in the anisocotylocytosis, like the shape and the size of the cells can be different. And these patients, they will require blood transfusion. And then there is secondary hemochromatosis. Why secondary hemochromatosis? Because we are giving more blood to these people. And then there is iron overload, and we read that iron cannot go out of the body itself. We have to give the chelating agents, only then the iron can be pushed out of the body. And when you will not give blood, then their hemoglobin level will fall. So it is associated with expansion of the bone marrow space, and we can have skeletal deformities, and then there can be extramedullary hematopoiesis. Patient will have hepatosplenomegaly, increased risk of pyro B19 infection, and then if there is infection due to the B19, it will cause cleaning of the whole bone marrow. So there will be aplastic anemia. So in this case, hemoglobin F will increase, and the composition is alpha 2 and gamma 2. And hemoglobin A2, the composition is alpha 2 and delta 2. So hemoglobin F is protective in the infant, and the disease becomes symptomatic only after 6 months when the fetal hemoglobin level will decline. We read about this also yesterday. So then there are many other variants which you don't have to remember, because from the hemoglobinopathies, they are going to ask you just very few things. So hemoglobin S, so the beta thalassemia heterozygous, if there are S genes. Patient can have mild to moderate sickle cell disease depending upon the amount of the beta globin production. This is just like trade. So now look at these pictures like, okay, so beta thalassemia minor, major, I have told you. So these patients, they will need regular, the thalassemics, they will need regular therapy, and they will need chelating agents also like desferrioxamine. So dafracirox and dafraperidone, they are not safe in pregnancy, but desferrioxamine, it can be given safely in the pregnancy. So then another inherited disorder, that is sickle cell disease. So what can you tell me about sickle cell disease? You know, the notes are also available in your on your web page. So this is a defect in which what has happened, there is a single base mutation. Bases, you know that there are four types of bases. So what happens here, that adenine to thymine, you know, some changes have taken place, and it will produce substitution of valine for glutamic acid at the 6th codon of the beta globin chain. So this is autosomal recessive trait. So single amino acid point mutation and glutamic acid at position number 6 has been replaced with valine, another amino acid. So defective hemoglobin. So when there is less oxygen due to oxidative stress, the hemoglobin will condense and it will adopt a sickle shape like moon, or like this sickle that we are using to cut the crops. So it can be homozygous. Homozygous, then your patient will be hemoglobin SS, and both genes will be abnormal and the person will get sickle cell disease. If just one gene is abnormal, then they are going to have sickle cell trait. So if then there can be like many other things, but you don't have to remember all variants. Just remember that if there is less oxygen, then this S hemoglobin, it will change its shape because it is going to polymerize and it will cause sickling. Normally the RBCs, they should appear as the biconcave disc, okay, but now they will appear like a sickle. So how this sickling is precipitated? If there is infection, dehydration, cold, acidosis, or hypoxia. So if your patient is having these problems, then we have to tell them that they should avoid having all of these conditions. So then what occurs? Like if you remember, the lifespan of the RBCs is 120 days. But now when the RBCs, they become like sickle, they cannot pass through the blood vessels, small blood vessels, basically capillaries. So they will be broken down. So it will lead to increased hemolysis. Then the second problem, the second part of pathology is that these sickle shaped cells, they are going to block the microcirculation. They can form a clot or they can block the circulation. That's why when this blood supply is cut off, it will result in ischemia and injury and death of that tissue. That is the point, okay? So that's why, you know, and how it is treated, it is given by treated by given hydroxyurea. That will prevent crystallization of these things. If you have a patient with sickle cell disease, you know that you need to give them special care in the consultant unit. Multidisciplinary team should be there, and they will give them specific, you know, if she's pregnant, she cannot take hydroxyurea. She has to stop it 3 months before uh, conception. So again, if she has anemia and she is becoming symptomatic, we will have to give her blood transfusion so they can also have, you know, this blood overload. Iron overload can be there. That is the point. So then going to the other types of disorders, chronic disease like the autoimmune disorders can be there, or any chronic disease for that matter, it can result in anemia. Again, in the chronic disease, serum iron will be low. Then TIBC, it will also be low. And you should remember, if there is iron deficiency anemia, then the TIBC is going to increase. Then ferritin, it will increase in the chronic disease. And the percent of the transferrin saturation, it will decrease. If there is hemochromatosis, like this is primary hemochromatosis, which is a disorder in which the person is storing iron into the different body tissues, or it is secondary to the blood transfusions. your patient is going to have some problem. Okay? So the iron load, serum iron, it will increase. Then TIBC, it will decrease. Because the most of the sites, they will be saturated with the iron, so the iron binding capacity will decrease because already all sites are occupied by the blood. Serum ferritin, the storage form is going to increase, and saturation of the transferrin, it will also increase. Why? Because there is more serum iron and there is more binding capacity, so everything will and less binding capacity, too much iron in the system, so the percent transferrin saturation, it will also increase. In pregnancy, or when the lady is taking combined oral contraceptive pills, when she's taking COCPs, her body profile is going to be the same as in the pregnancy. So no iron deficiency anemia, but the transferrin or the total iron binding capacity, it will increase. No effect on the ferritin, and the transferrin saturation, it will decrease. That is the point. So if you will ask about the transferrin, you should remember that this is going to transport iron in the blood. TIBC, it indirectly measures the transferrin, that what is the level of this transferrin. If more transferrin is there, then of course this is going to be it is going to be the opposite. If it is low, then the TIBC will increase. Ferritin, this is the primary storage protein of the body. This is for the iron. Okay. So you should remember these three things because you are going to get one question from here like that. That is the point. Now talking about the less common causes of the anemia. Hereditary spherocytosis, like primarily this is autosomal dominant, and what happens here, the primary autosomal dominant and defective protein, they will interact with the RBC's membrane, and the skeleton and the plasma membranes, they are abnormal. So what will happen, that their diameters are, they will have like small round RBCs with less surface area, and they will not have a central palate. Why? Because a major is this hemoglobin concentration of the corpuscular hemoglobin concentration, that will be higher, and there will be premature removal by the spleen. So that is the point, that there will be too much breakdown. So the patient is going to have extravascular hemolysis. Why extravascular hemolysis? Because it is taking place in the spleen. Another, so here the patient can present with splenomegaly. They can have a plastic crisis in response to parvovirus. That's all you need to remember. Okay. In glucose 6-phosphate dehydrogenase deficiency, this is X-linked recessive. There is defect in the glucose 6-phosphate dehydrogenase. So the nicotinamide, reduced form of nicotinamide, it will decrease. So it is going to decrease the glutathione. So what will happen? The number of the RBCs, that it will increase more oxygen. This is glutathione is active against the reactive oxygen. Okay, but when its level is low, then there is going to be more oxidative stress on the RBCs. Okay, and as such, these people, they will have no problem. But when they will take sulfa drugs like sulfamethoxazole, sulfonamides, then or like trimethoprim also, they can have hemolysis. Then if they are taking anti-malarial drugs, or if they are eating fava beans or the broad beans, then they are going to develop hemolysis. So this type of G6 phosphatase dehydrogenase, pyruvate dehydrogenase deficiency, it is going to cause both intravascular as well as extravascular hemolysis. Then remember, this deficiency and the pyruvate kinase deficiency, these are different. Even the etiology is different. Glucose 6-phosphate dehydrogenase, this is X-linked recessive, and pyruvate kinase, this is autosomal recessive. So pyruvate kinase defect is there is less ATP, so a rigid RBCs so rigid RBCs means that they're not flexible, they cannot pass through the blood vessels, so we are going to have hemolysis. So then what happens, there is also increased level of 2,3 biphosphoglycerate. So it means that if there is higher level of 2,3 BPG, then it will decrease affinity of hemoglobin for oxygen. So it can also cause hemolytic anemia in the newborn. Regarding paroxysmal nocturnal hemoglobinuria, here the hematopoietic cells, they will under stem cells, there is some mutation. So there is increased complement mediated intravascular hemolysis, especially at the night time. So these patients, they will have PIGA receptor mutation. So there will be impaired GPI anchor synthesis. So the structure is going to be defective. And these persons, they will also have, synthesis for the decay accelerating factor. It will also be impaired. So as a result, what will be happen? The patient is going to have problem with the RBC membrane, and then complement mediated intravascular hemolysis will take place. So what will happen in this case? In PNH, the Coombs test, it will be negative. There will be hemolytic anemia, but the Coombs test will be negative. There will be pancytopenia, and there can be venous thrombosis. So once the typical story will be that when the patient gets up in the morning, he is passing pink, red, brown urine. So it is associated with aplastic anemia, also with acute leukemia. If we will do the test in the lab, then the CD55, 59, they will be negative, and the RBCs, these will be negative on the cell surface of the RBCs, and we can recognize it on the flow cytometry. Then treatment of this disorder, since this is autoimmune, right? So what we have to do, like we will give them, biologics, like eculizumab, it can be given. So they are going to affect terminal complement protein CS, and then the condition can improve in such patients. This is the sickling of the cells. Okay. Then you should remember that what will happen, that such patients who are having like anemia, you will need to give them prophylaxis against encapsulated bacteria. Which capsulated bacteria? Haemophilus influenza, meningitis, and the pneumococcus. So you will have to give them flu vax every year, and pneumovax you will have to give them every 5 years. So that's all you need to remember about anemias during pregnancy. So if your patient has megaloblastic anemia, you will need to see that the serum vitamin B12, what is the level? Is it normal or it is abnormal? Because if it is abnormal, then it means that you will have to give them folic acid and vitamin B12. The treatment will depend that what exactly is the defect. So that's all you need to remember about anemia. So I think